the first session. I think it was an excellent discussion and great information shared by all the speakers. Moving on to the next presentation, I would like to introduce Alan Gross from UIC. I've been fortunate to work with Alan for a number of years in ID pharmacy and antimicrobial stewardship. And he's the lead antimicrobial stewardship pharmacist at the University of Illinois, Chicago, and a clinical associate professor. He received his PharmD from Purdue and subsequently completed a PGY1 at Henry Ford Hospital, and a PGY2 at Midwestern, and with us at Northwestern as well. So I had a chance to work with Alan as a PGY2 resident. He's active with many professional organizations and currently serves as board member at large for the Society of Infectious Diseases Pharmacists. He has previously served as chair for the SIDP Policy and Government Affairs Committee and the SIDP Antimicrobial Stewardship Committee. His primary research interests include the measurement of outcomes related to antimicrobial stewardship interventions, as well as the epidemiology and treatment of respiratory tract infections. He serves as a co-editor for the American College of Clinical Pharmacy Infectious Diseases Self-Assessment Program. Alan will be presenting on latest updates in antimicrobial stewardship literature. Go ahead, Alan.
Thanks a lot, Mike, for that introduction, and I love being introduced by my mentor. Appreciate it. So I'd like to also thank IDPH and Shannon and Jamie and for all their work on this. It's been a great event. I was just sharing with them. I literally got the idea for one of our stewardship interventions a few years ago from this event. So hope everybody's enjoying it. And it's in that spirit that I'll be, let's see here. Can everybody see my screen? Okay. All right. And so it's in that spirit that I'm going to be kind of sharing some updates on the latest literature in antimicrobial stewardship. No disclosures. And so I'm really going to be focusing on studies that were published in the past year, focusing on studies that I think should be fairly impactful, things you can take away and apply at the bedside. There's certainly been a lot of literature on COVID-19, but frankly, I've completely ignored those because I think if you're dealing with that, you're familiar with it, and frankly, it's nice to focus on something that's not related to COVID-19. So we'll be talking about some various articles on stewardship. And so the first one we're going to talk about is entitled Administration of Beta-lactam prior to Vanco as the first dose of antibiotic therapy, improved survival in patients with bloodstream infections. And so this was a retrospective cohort study of patients that were at least 13 years of age with a bacterial bloodstream infection that were hospitalized within the Johns Hopkins hospital network. The authors excluded patients who did not complete at least one dose of those agents within 6 hours of blood collection, if they received both agents at the same time, so co-infusion, or they received antibiotics prior to blood culture collection, or that the patients were infected with contaminants or non-bacterial organisms. So pretty reasonable exclusion criteria to really address the question at hand. Again, this was a retrospective study, and the exposure was receipt of beta-lactam, so either piptazo, cephalosporins, carbapenems, or aztreonam prior to receiving vancomycin, okay? And then they looked at both the overall cohort, and they also did a propensity score matched cohort. The primary outcome they looked at was mortality within 7 days of blood culture collection. And so they included 3,300 patients. Most of the patients that were excluded were for overlapping administration times and patients who did not receive either beta-lactam or Vanco. Most of the patients in the study received the beta-lactam first, 80%. 80% had a blood culture taken in the ED, 13% in the general ward. Most common beta-lactams used in the study were piptazo and cefepime. And then the most common bacteria that patients were infected with for their bloodstream infections were Staph aureus, E. coli, and Kleb pneumo. So, I mean, frankly, if you're practicing in a hospital in Chicago, this patient population probably is going to look somewhat similar to your own in terms of what they're treated with, what they're infected with, where cultures are taken, et cetera. When we look at the demographics of the patients at baseline, You can see the average age was around 65, about 45% were female, et cetera. And 73% had active agent administered as their empiric regimen. When we looked at the primary outcome for 7-day mortality, it occurred in about 7% in the beta-lactam group versus 10.7% in the vancomycin group, and that was statistically significant. And so you can look at the unadjusted analysis here. Again, lower odds of mortality in patients that received that beta-lactam first. And then when they adjusted it for the propensity score to kind of help control for some of the baseline differences, they found that it still was associated with decreased risk of mortality. So administering that beta-lactam before vancomycin as part of their empiric regimen for patients who were septic and ended up with bacteremias was associated with decreased mortality. So, first, do we believe the study? Anytime we have a retrospective study, we need to make sure that we agree that there's some biologic plausibility here. I think there's at least two reasons to believe this study and think that beta-lactams first might be associated with decreased mortality. First, as you guys saw, most of the bacteria were gram-negative, and gram-negative etiologies are typically associated with higher mortality, and they're more virulent than, for example, like enterococcus. And so if we're giving the agents that are active for those first, maybe they would be associated with decreased mortality. Secondly, you could look at it from a frequentist approach and which agent is going to be active for the pathogens that are most frequently observed in our patients that are bacteremic. And certainly MSSA will be covered by piptazo, encefapime, our carbapenems. And then obviously most of our gram-negatives are going to be covered by these agents as well. And so really the main thing we're missing is MRSA coverage, maybe VRE or something, but that wouldn't matter anyway. So from a frequentist approach too, giving the beta-lactam first as part of an empiric regimen really makes sense. They did look at a subgroup analysis of the patients that did have MRSA bloodstream infection. And those that received beta-lactam first did not have an increased risk of mortality, although that was a limited analysis. So this is a really simple intervention, right? Just educating around administering our beta-lactams first, potentially facilitating that through the electronic health record and order sets. And I know there's a lot of nurses that are participating in today's event. And I would say, if this hasn't been a discussion and you're a part of your antibiotic treatment teams or administering your antibiotics to your patients or helping drive those decisions, I would bring the study back to the stewardship team and say, hey, have you guys seen this? What do you think about this? Is this something simple we can implement in our own institution to potentially save some lives? So I would definitely encourage you all to start educating around this. When this study came out in October of last year, it was something I kind of educated around during Antibiotic Awareness Week in November, and something we were pushing for. And I think this is a good example of a study that's not a randomized controlled trial, but it's a retrospective cohort study that actually I think we can apply at the bedside and has impact. The next study we're going to talk about is entitled Pharmacist-Driven Transitions of Care Practice Model for Prescribing Oral Antimicrobials at Hospital Discharge. So this is a study looking at the transition of care from inpatient to outpatient. This was just published 2 months ago in JAMA Network Open from our colleagues at Henry Ford Hospital in Detroit. And so it included adults that were discharged from 5 hospitals within the health system. It excluded patients with cystic fibrosis or pregnant, receiving OPAT, or had other kind of complicated infections. This was a stepped wedge implementation, and I'll talk a little bit more about that in the next slide. But they did this to help control for secular trends over time. The intervention varied according to kind of the local transition of care, practice, and resources, because within Henry Ford Health System, there's community hospitals, there's an academic health center, and obviously, as we know, all hospitals are going to have a little bit of different structure, resources, and processes related to this. But they were able to adapt it locally for each institution. And so this was a pharmacist-driven approach. Pharmacists identified patients that were approaching discharge that had active antimicrobial orders, and they developed collaborative plans with the medical team related to agent selection, duration, and they ordered the med to be signed by the primary physician at discharge. Pharmacists received mandatory competency sessions related to workflow and order entry, and then they documented in the electronic medical record what the plan was. The uptake of the intervention was enhanced through physician champions, updates at departmental meetings, signed letters of support, photos posted from the healthcare team to kind of get at that psychological aspect of making a dedicated effort towards this intervention. And they monitored protocol adherence. So again, this is not kind of a light intervention, something simple, probably that like the last study we talked about, this is more of a intensive intervention focused on transitions of care. And the primary outcome was the frequency of discharge with optimized antimicrobial regimens according to their guidelines. Secondarily, they looked at some of these other outcomes, length of stay, duration of therapy, 30-day readmissions, mortality, et cetera. And so this is what kind of the study looked like in terms of the patients that were enrolled. Again, it was stepped wedge. And so with the first group, this is the academic hospital service team. They were kind of the most ready to implement the intervention. So they kind of started with them first. They had one pre-intervention period, like 1/4 of pre-intervention, and then 3/4 of intervention. The next group was a mix of academic and community hospital teams. 2/4 of pre-intervention followed by 2 intervention. And then group 3 was just community service teams, including hospitalists and internal medicine. And so again, implementing the step wedge design helps control for time bias that might occur with a secular trend that's already in place. So they included 800 patients in the study, 400 pre-intervention and 400 post. The most common infections, nothing too surprising. You might expect pneumonia is going to be one of the more common things, COPD, UTI, and skin infections. And then this is the proportion of patients receiving optimal prescription at discharge. So overall, in the entire cohort, pre-intervention, only 36% of patients received optimal prescription at discharge versus 81% post-intervention. And that was statistically significant, of course. So the absolute difference there is pretty remarkable. They also kind of stratified these outcomes by community versus academic hospital. And so you can see the academic hospital, they kind of started a little bit higher in terms of their concordance with hospital guidelines, but still had a significant improvement. Community hospitals started a little bit lower, about 1/3 of them, but again, a significant improvement. So regardless of the setting, whether it's community or academic, this was a very impactful intervention. When you look at the components of non-optimal prescribing that were actually modified through this intervention, prolonged duration was probably the biggest yield. And I think I'm not too surprised by that. I'm sure many of you who are involved in these decisions or seeing patients as they get discharged, a lot of times the medical team is like, okay, we're gonna do 7 days of levofloxacin or whatever the drug is for the patient. And it's like, well, please incorporate the duration that they already received, right? And make that 4 days. And maybe that gets lost in the communication. So I think this is a big opportunity here for focusing on. Other studies have demonstrated that prolonged duration is a major opportunity at the transition of care from inpatient to outpatient. Non-guideline concordance selection. This was also a pretty big area that they improved as well. That improved quite a bit from 20% non-guideline concordant to 6% after. So I think that's super important. We should probably be using the most effective, least dangerous antibiotics upon discharge. They also looked at the days of therapy, and so this was associated with an absolute decrease of 1.1 days of therapy, days of antibiotic therapy. The secondary kind of patient outcomes they looked at, mortality, we're not necessarily going to expect a change in mortality with this intervention, and we didn't find one, that's fine. In terms of any adverse drug event, overall, there was, an improvement in the non-time adjusted analysis. Time adjusted, there was no difference. Specifically for severe drug events, though, that was a statistically significant difference, both in unadjusted and adjusted analyses. So 9% in the pre-intervention, 3% post-intervention. No difference in CDI, but again, these are uncommon events, but you can see a numeric potential benefit there. And if you're decreasing duration of therapy, it's not too surprising that you might see a decrease, maybe modest decrease in adverse events. Also saw, interestingly, a decrease in multi-drug resistant acquisition at 90 days. So some takeaways for this study. Transitioning care from inpatient to outpatient is complex. There's a lot of moving parts with our discharge planners, with ensuring they have coverage, getting them the drug, et cetera. And collaboration among the healthcare team is super important to make these plans clear. And so there's a lot of opportunity here. This isn't the only study that kind of underlines that opportunity. There's a lot of studies showing inappropriately prolonged durations of discharge. And so we need to be focusing on these things as stewards. And so I think takeaways from this study, I think the transition of care, if you look at the literature, really there's maybe 2 other studies tops that are like pretty decent that actually address this. It's a challenging thing to address and really operationalize. But they were able to do it at their own centers, and 5 different centers with different structures. And I think some easy things we can do is make sure in your institutional guidelines, whether it's just for inpatient treatment of disease states or you start to include some discharge recommendations or transition recommendations, make sure you're including durations and de-escalations. Educate around them. You can operationalize these in the order sets, in annual education and competencies, pocket references, et cetera, just the normal ways we kind of educate our teams. Audit and feedback, targeted care transitions. I think if you can implement that, you're going to have a lot of benefit. And so again, looking at opportunities to do this is super important. And I think there's ways we can do this. So Henry Ford actually put together a toolkit at this link. And I've linked this here too. You can kind of see what's going on. But they have some strategies, based on different settings and different resources, whether it's community or academic hospital, gap analysis tool, et cetera. So I definitely encourage you to take a look at this. Think about the transition of care. I know a lot of our stewardship programs are kind of overtaxed and maybe under-resourced, but this is definitely an ascent area that we need to be focusing on because there's a lot of opportunity. Our next study I'm going to talk about is actually a randomized controlled trial that looked at 7 versus 14 days of antibiotic therapy for treatment of afebrile men with urinary tract infection. As we know, a lot of studies have been looking at durations of therapy over the years, thankfully. And I think the duration in men is still kind of an area that we struggle with, and guidelines still recommend kind of a general 7 to 14 days for these patients. So they were trying to address this with this study. They included adult outpatient males with symptomatic UTI, which included flank pain. So they allowed patients to be included who may have had pyelonephritis. They excluded patients, though, that were febrile, who had a prior UTI within 14 days, or the pathogen was not susceptible to the agents that were used. It was double-blind, placebo-controlled, randomized, and these were done in VA medical centers. The intervention was patients received either these 2 agents, Cipro or Bactrim, and were randomized to 7 to 14 days, 7 or 14 days. The primary outcome was resolution of initial UTI symptoms by day 14 after treatment. Secondary was recurrence of UTI or adverse events through day 28 after stopping therapy. 272 patients were randomized. The mean age, these are elderly gentlemen, or just older gentlemen, I should say. Median age was 69 years, 145 had positive urine cultures. And then when we look at resolution of UTI symptoms 14 days after stopping active therapy, which was the primary endpoint, you can see 93% versus 90% in the 14-day group had resolution of UTI symptoms, and that was no statistically significant difference. It did not cross the lower bound of their non-inferiority margin of minus 10%. In the as randomized population, which was kind of the more broad analysis, which even included patients who maybe didn't receive all their therapy and things like that, also no difference. And they looked at the secondary outcome of recurrence of UTI symptoms at day 28. The as-treated population, that occurred in about 10% of patients versus about 13% of patients in the 14-day group. So again, no signal there of any difference, and the point estimate there even favors the shorter duration of therapy. So I think this study, and they looked at no different adverse events as well. There's no difference in groups between 7 days and 14 days. So takeaways, they didn't really meet actually their initial kind of planned power, I think, for this study. So the analysis and finding of no difference is somewhat limited, but I think we are encouraged by the fact that the point estimate kind of favored almost the 7-day duration in both arms, and I think this is fair. And there's other studies also looking at this that are non-randomized that suggest that 7 days are probably adequate in this patient population. Only 2/3 of patients had a documented culture, which is also kind of a problem, but it also reflects kind of real world care. This is a difficult diagnosis in men, right? It can be confounded by, does the patient have bacterial prostatitis, for example? But, they excluded patients that were febrile and things like that. And again, I think not really any signal that this would be any worse. They use Cipro and Bactrim. They did kind of compare the outcomes between those two. There wasn't technically a difference in outcomes between those two treatments, but that does kind of cloud, which one are these both effective? Is one more effective than the other? We can't really say for sure. But this was a pragmatic trial design. There was also no difference in outcome based on the number of colony forming units or lack of positive culture. No difference by the two treatment sites. So I think, again, we need to be thinking about durations for all of our patients and all indications, but this is just additional, pretty high quality data that suggests 7 days is probably adequate in afebrile men with UTIs. And I think I was talking with one of my close colleagues about this too, and she brought up the good point that, even in studies where we have patients that are bacteremic, gram-negative bacteremia, right? We've got randomized controlled trial from Yahav showing that 7 days is adequate for them. And certainly, most of the time, if it's good enough for a gram-negative bloodstream infection, it's probably good enough for a UTI, for example, too. We've got data for VAP as well, so that 7 days is fine. So even for more severe infections, we know 7 days is fine. And for these agents that concentrate well in the urine, I'm pretty safe, I think, in using 7 days of therapy. The next study we're going to talk about is the impact of antibiotic stewardship rounds in the intensive care unit, prospective cluster randomized crossover study. So this was done at Duke. This was an inpatient study of adult ICU inpatients with anti-infective orders. They excluded patients with an ID consult, patients who had received a hematologic or solid organ transplant, patients with ventricular assist devices or on ECMO. And it was a 2-arm cluster randomized crossover trial among 5 ICUs. And so I'll show this in a kind of figure in the next slide, but each ICU in their hospital is at baseline, they're just split in 2 half units. And so each of those half units have their own independent rounding teams. But, so for example, each cardiac ICU, or in their cardiac ICU, one half of the unit is split with a different rounding team than the other, but it's the same type of patient population. So this makes a very nice environment for conducting a kind of controlled, randomized kind of controlled trial. The intervention was a weekly antimicrobial stewardship handshake rounds conducted by the MD and PharmD at scheduled times, in addition to the routine pharmacist-led post-prescription review. The primary outcomes were antibiotic days of therapy per 1,000 patient days present during their initial ICU stay and the remainder of hospitalization. And so this is kind of the schematic of the study and how it was done. They did have a baseline period of data collection, I think of about 10 months or something, where they did no interventions whatsoever and were just looking at the durations of therapy and antibiotic use. Then during months 1 through 4, this is where they started to do the intervention. In half of in the ICU units, they did the antibiotic stewardship rounds. The other half just had usual care. And then after those 4 months, they did the crossover, and the unexposed half unit received the intervention, and the exposed unit then went back to usual care. So they had 2,300 intervention patients during this period. Pneumonia was the most common presumed infection, which is, again, not surprising. It's just kind of the catch-all, unfortunately, for inpatients. 760 patients were actively discussed during weekly multidisciplinary antimicrobial stewardship rounds. I want to stress these rounds, these were like scheduled rounds at set times. And so the cardiac ICU, the medical ICU, et cetera, they knew, all right, Tuesdays at 2 p.m., the stewardship team is going to swing by and they're going to chat to us about our patients, and we'll have some dialogue. And so they had at least one recommendation was made by the ASP team, and 98% of those patients, the most common interventions they made was, hey, let's define a stop date, which I think that's a super important one to have for ICU patients, right? Sometimes we don't think about what the stop date is, and things just continue forever, and people aren't readdressing them. So defining a stop date and putting that in the electronic health record with the order, super important. Stop date, stop antibiotics on day of review, that was a common one. Other workup for diagnostics, de-escalations, et cetera. 78% of the recommendations made were accepted by day 7. And so their primary outcome of ICU duration of therapy, or days of therapy, I should say, in the control group was 3. The intervention group was also 3, and there's no statistically significant difference. And so that's comparing the, during the intervention period, those 8 months, the intervention groups compared to the control groups, okay? No difference. For hospitalization, so even after they got discharged out of the ICU onto the general medical floor, the days of therapy was 5 in both groups, also no difference. So kind of discouraging. Now, when they look at, I mentioned they had this baseline period of about 10 months, of antibiotic use. They had the 8-month study period. And then after the intervention, they also looked to see what the antibiotic use was, to see if there was some kind of lingering effects or impact of their intervention. And they compare the pre-period to the post-period, and they look at the percent decrease in antibiotic use. They found that different units had kind of a different percentage decrease. Overall, there was a 16% decrease before and after. The cardiothoracic, there was essentially no change. But the other units seem to have more of an impact in terms of before and after the study period. Now, they're just looking at the percent change before and after the intervention. So that's not really controlling for the secular trend very well if this was already moving in the downward slope prior to any intervention. But I think it's reasonable to expect that you would have some impact of these interventions, some education, some lasting impact, hopefully, after this intervention. So, is this an impactful intervention? I think, during the intervention, they couldn't really document that. Before and after, maybe something. Doing stewardship in the ICU is hard. They did, these are complex patients. I think, being at the bedside is helpful, and meeting face-to-face with the team is probably helpful. And they were only doing these stewardship rounds once a week. And so, I put the only in parentheticals there. That's still to be, that's still laudable, right? That's more than most of us are doing, I think. And again, it's a significant resource on the stewardship team if you don't have many folks involved. So I think that might have limited their impact, but again, it's sometimes that's as best as we can do if we can even do that. They mentioned, 5 ICUs were involved with different team cultures and patient populations. Certainly, we've observed that in our own hospitals. We know that certain teams, certain units are a little bit more challenging in terms of getting our antibiotics changed or stopped than others. And so that's something they observed, and that's something we know is present. The outcome assessment included drug use from patients that were excluded, so that could have limited their perceived impact as well. They commented, that qualitatively the local stewardship team now has a greater understanding for ICU perspectives and treatment approaches. And I think that's an ancillary benefit to this intervention. And I think we should definitely be, if not going physically to the ICU, paying a close attention, having those phone call conversations. And then if we have time, going up to the ICU, talking with them and things like that, and maybe scheduling a time once a week, if not more, to chat with them. Our final guideline here, and I've got, our final manuscript I'll talk about. We've got maybe a minute or two left. This one's not necessarily a study, but I thought it was worth including for a few reasons. Number one, it's kind of a new guideline that just came out again like 2 months ago. there's not there, we've got a pediatric osteo guideline from IDSA, we've got a vertebral osteo guideline from IDSA, but not just any general osteomyelitis guideline in adults. And so this group led by Brad Spellberg led a guideline developed with kind of a new method, which I think is interesting. And they kind of were spurred to do this because there's a dissociation between strength of recommendation and quality of evidence in IDSA guidelines. Some colleagues and I in drug information at UIC as well, we kind of looked at strength of recommendation and quality of evidence a year or two ago, and we found it's still a major issue where we're providing maybe strong recommendations based on weak data in the IDSA guidelines. And so that was actually a major part of the impetus, that this long known issue in IDSA guidelines. And so this wasn't just, hey, let's round up 25 people and write a guideline. Like, they developed a charter for wiki guidelines, and they're going to create other guidelines as well. And if you look at the charter, it's, I don't know, like 50 or 60 pages. It's significant effort and thought went into developing the structure and process with the development of these guidelines. And, they only want to make recommendations where at least 2 high quality studies exist. One of those has to be an adequately powered randomized controlled trial. Okay, so this is kind of getting at that. Let's not make strong recommendations when we don't have good data. Let's have a little bit more, measure and potentially humility and understanding the limits of our knowledge. But where no high quality studies exist, we can still provide kind of a clinical review evaluating the risk benefits of approaches, considering the needs of the health system, the patient's perspectives, et cetera. Sought to incorporate principles of high value care and healthcare equity. And then if there were divergent opinions among guideline authors, they highlighted those, right? So they said, half the folks said we should do this, the other half said maybe not. So these are the 7 questions they assist with this kind of new approach. Only 2 of these were there adequate randomized controlled trial data and other high quality data to actually answer what is appropriate duration. And then what we'll talk about first is oral therapy appropriate for the treatment of osteo? And if so, what are patient selection criteria for administration? So that first one that have adequate data, you can see there's multiple randomized controlled trials actually comparing IV to oral therapy for osteomyelitis. And most of these patients have had adequate debridement and things. And so no difference is, long story short. And so I think this continues to be an issue. We need to kind of get rid of the idea that IV antibiotics are magic, because they're not. If we have an oral agent and the patient is absorbing adequately, then we should be okay with that. And we've got randomized studies that can guide us. And the guideline authors also qualified, okay, who are the patients we should be doing this for? Well, it should be okay for empiric use, as long as we're covering what we think we need to be covering. It's okay when we're not requiring further procedural drainage and when there's not ongoing bacteremia, okay? So we need to be thinking about doing oral therapy. There's not like a period of time where we should be doing IV therapy empirically, as long as we have adequate empiric coverage, is their suggestion, and I tend to agree. Duration of therapy for osteomyelitis without retained implant, including diabetic foot osteo, maximum of 6 weeks. We've got 2 randomized controlled trials, one in vertebral osteo, one in actually diabetic foot infections with osteo. Both of those studies, actually, if you want to look at them, were in 2015. They both found no difference in 6 versus 12 weeks. So maximum 6 weeks. You can take a look at the guidelines, since I'm running out of time here if you want to look more. So to summarize, I think this is an exciting and an interesting approach, a pragmatic approach to guideline development. And it potentially facilitates easier and more patient-specific application of recommendations to the bedside. These are going to be living documents. They're going to update these as new high-quality data exist. And I think this is kind of a new paradigm. If you know Brad Spellberg and kind of where he stands on things, he frequently, I think, annoys and calls out the IDSA. I think this competition is good. It's to some extent, if you want to even call it competition, but I think this other perspective is good and this other approach. Because sometimes when you see the guideline recommendations from IDSA, they just may not be practical. So with that, I hope, with these 5 kind of articles I reviewed, I hope you took something you can take back to the bedside, something to open up discussion with your colleagues at your institutions. And with that, I know we're out of time, but I might take one question, and I know another session has probably just begun if you want to go to that as well. Thank you.
Thank you, Alan, for that great overview of some very interesting studies. We do have one question here that is related to the first paper you presented, which asks how many patients had MRSA and what was their outcome, if that was available in the study. And the second, I think, is probably in the slide, and what was its reference?
Yep, good question. The number with MRSA, I would have to look back exactly, but it was something like 200 or something. So it was, it was a minority of patients. It wasn't more than like 10% of the total patient population. So it would have been somewhere around 200. And, they did look and see, in that population who got a beta-lactam first, did they have a worse outcome? And they didn't. They were limited by power, but that was reassuring. I didn't catch the second question, sorry.
Second question, I think related to the reference for the paper, which I think you had on your slide. So,
oh, gotcha. Yep.
So that'll be available afterwards. People can go back to that. And that's really the only question. Again, I'd like to thank you, Ellen. I'd like to thank everyone who attended. I think this was a great session and appreciate all the great information you provided.
Thanks, everybody. Take care.